Hello, and welcome to our session of education regarding the proper use of benzodiazepine medications, which we have chosen to call How Bad Things Happen with Good Prescriptions. This is provided under the auspices of the Mayer Institute for Excellence in Therapeutics for Elders with Dementia, which is a part of the Marshall University Joan C. Edwards School of Medicine. I am Dr. Shirley Nitch, geriatrician and the Mayer Professor of Clinical Geriatrics. We have a two-part program for you regarding prescribing medications, which has been supported by a grant from the Benedum Foundation for the Rational Benzodiazepine Avoidance and De-prescribing Strategies grant generously received from them. And our goal for this educational program is for participants to be able to safely both prescribe and de-prescribe the benzodiazepines. Our objectives will be recognition of the pharmacologic properties, operationalization of principles of good benzo-prescribing, evaluation of patients for evidence of misuse or excess use of benzos, de-prescribing strategies, and then finally formulation of individual treatment plans for patients who need to discontinue their benzos. In the first section of this curriculum, we are going to cover these first two objectives: review of the pharmacologic properties of benzos and the principles of good benzodiazepine prescribing. The benzodiazepine class of medications was actually serendipitously discovered in the mid-1950s when scientists were actually looking for a substitute for the barbiturate group of medications. They recognized that those medications, while effective, were fraught with a number of possibilities, and so quite a bit of research was undertaken. The very first one that was actually well defined was chlordiazepine epoxide, discovered by a Roche Laboratories scientist, Dr. Leo Sternbach. It took them 3 years to develop that into a marketable therapeutic medication, and it was put on the market under the brand name Librium, and the very, very well-known Valium was released a few years later in 1963. Benzodiazepines function by binding to the GABA A receptors, increasing the activities of endogenous GABA. Now, as you know, this is the brain's inhibitory neurotransmitter, and consequently, the clinical effects are as you might expect. We are able to prescribe this class of medications as sedatives, hypnotics, anticonvulsants, anti-anxiety agents, and also as muscle relaxants. I think everyone is aware that these have been very successful, commercially speaking, and there are certain pros to prescribing benzodiazepines, as well as certain cons, which we'll discuss a bit later. The main pro is that these are highly efficacious medications. They work. They do what they are supposed to do. And fortunately, if they are used alone, the toxicity of these medications is actually quite low. The side effects are few and relatively mild in the vast majority of patients. They would consist of drowsiness, perhaps in certain patients a decreased respiratory rate, sometimes some loss of appetite, and so forth. If used alone, there is actually very little risk of death from overdose with benzodiazepines. Now, obviously, one can take a sufficient amount to lead to one's demise, but that is not what usually happens. benzos are much more likely to lead to overdose death if they are taken in concert with opioids. And this slide will show you how, over the years, the number of overdose deaths from benzos alone has remained fairly consistent and relatively low, somewhere between 500 to 600 and perhaps 1,000 persons per year in the entire country. You only have to look at the red line to realize that when coupled with opioid use, the death rate from overdose of benzos plus opioids is considerably higher. In 2015, for example, you can see that rather than just 1,000 or less, the number of deaths was much closer to 7,500. Now, we mentioned that there certainly were some cons to prescribing benzodiazepines, and perhaps it would be reasonable to say that one of the cons is that they work. Perhaps they even work too well. It has been said that benzodiazepines can reinforce their own administration. Patients will notice either a euphorogenic or a calming effect. And when these medications are used, as they frequently are for social anxiety disorder, then the effect of the drug and the secondary side effects actually will be reinforcing. They make the person less anxious in social situations, and that's exactly the reason why the medication was being used in the first place. Now, the next significant contraindication to prescribing benzos is that physical tolerance does occur, and there is clearly an abuse potential. It is not huge. The lifetime prevalence of benzo abuse disorder is probably in the neighborhood of 1%. Now, when co-prescribed with other drugs of abuse, it is rather hard to get a handle on the prevalence of this kind of abuse disorder. It is higher than 1%, but good numbers are somewhat hard to come by. Additional cons of prescribing benzos include some of the direct side effects and some of the outcomes of those side effects. Delirium is certainly a possibility. Falls and fractures are known to be increased in prescribing benzos, and certainly for your elderly patients, this simply has to be a significant concern for anyone doing the prescribing. Motor vehicle accidents increase among drivers who take these medications, and there has been some concern and some data generated through the years that perhaps relatively long or relatively high use of benzodiazepines may actually increase the incidence of dementia in the years after these medications have been taken. One of the largest studies of the possibility of an association between benzo use and dementia was published in British Medical Journal in 2014. This group studied 1,800 patients at the time that they were diagnosed with Alzheimer's. They looked back in the records of these 1,800 patients for 6 years prior to the diagnosis for the presence of benzodiazepine prescriptions. And then they classified the entire group of 1,800 into never use or ever use. And in patients who had ever been given a benzo prescription, they further defined their cumulative dosing. Additionally, they looked at what medication had been given and noted the drug elimination half-life of the medication actually being taken by the patient. What they found was that being classified as every use, in other words, having been given a prescription sometime in the 6 years prior to your diagnosis, was associated with an increased risk of Alzheimer's. The adjusted odds ratio in fact, was 1.51, which is to say a 50% increase in the chance of being diagnosed with Alzheimer's. Now, it's important to note this is an association. It is not causation. They have not demonstrated that use of the medication caused the Alzheimer's. Perhaps it is that these patients had increased reason, increased symptoms, which would indicate that a benzodiazepine might be an adequate medication to use. Nevertheless, there is this association with increased Alzheimer's, and until such time as we are able to do the more detailed cellular level studies, it's important for us to know that certain statistics do apply in terms of association of use of these drugs with risk of Alzheimer's. Interestingly, they did determine that if a person had been prescribed 90 daily doses or fewer over the preceding 6 years, there was simply no association. If the person had been prescribed between 91 and 180 doses, the odds ratio was 1.32, 30% increase. If the person had been prescribed more than 180 doses, the risk was 1.84, or an 80% increase in risk. And as we said, they also looked at the half-life of the specific drug being used. Odds ratio was 1.43 for short half-life drugs and 1.7 for long half-life drugs. You won't be surprised to hear that there's been some controversy about this finding. A 2015 meta-analysis was done. There were only 6 available high-quality studies on which to do this meta-analysis, but there were 12,000 patients in those studies, and it confirmed the association. They found overall, through 6 studies, a 1.49 odds ratio. And they also have discovered that there is some evidence of a stronger association in persons with an increased genetic risk. The genetic risk in question is the one that you've almost certainly heard about before, that an increased number of E4 alleles of the apolipoprotein E gene will increase your risk of developing Alzheimer's. There are some important statistics that we ought to touch on before we go any further, just simply regarding our practices as prescribers of benzodiazepines and what we've been doing with these medications. These drugs have been available since the 60s. Over just the past 20 years, the prescribing of them has tripled, and fatal overdose cases involving them has quadrupled. The specific numbers of benzo-associated overdose deaths was 0.58 per 100,000 in 1999 and had risen all the way to 3.07 per 100,000 in 2013. It is interesting and important and frightening that the rising rate of overdose deaths seems to have leveled off somewhat around 2010 for all demographic groups except those older than 65. Now, opioid prescribing peaks around the age of 64, while benzo prescribing rate continues to rise with age. One of the things that's most striking about that is that the prescribing pattern is quite inconsistent with the diagnosis documentation. The diagnosis of anxiety disorders of all sorts, the peak age for that is around 30 to 45. And yet, our use or our prescribing for our patients' use of these drugs continues to rise with increasing age. We mentioned earlier that one of the problems with benzo prescribing is that there's an excess of collisions among drivers who have prescriptions for these medications or who have these medications in their system. There was a study published of West Virginia drivers over 65 in whom levels had been checked for benzodiazepines. 17% of those drivers over 65 years old tested positive for benzos. But another interesting factor there was that just less than half of that 17% actually had their own valid prescription for the medication. So these persons, clearly, a slight majority of them were taking unprescribed benzodiazepines. In West Virginia, the most commonly prescribed one is alprazolam or Xanax. Tied for second is clonazepam or Klonopin and lorazepam or Ativan. Now that is going to be important when we talk about the relative half-lives of these medications, because clonazepam is a long half-life medication, and for it to be prescribed second most commonly is a problematic issue. In 2015, specific data from the West Virginia Board of Pharmacy showed that the prescribing rate in West Virginia for persons over 65 was 1.67 per person. In other words, 1,067 prescriptions per 1,000 persons over 65, more than one prescription for every person. And clearly, that does not mean that all persons were given the prescriptions. It means that enough multiple scripts were given to patients over 65 that it ended up with this statistic, 1.067 per person. So let's shift now and start talking about some of the prescribing principles so that we can complete our little series here with good background in what we should be doing. Prescribing principles include that for the general population, these medications are used for a variety of issues, as sedatives, as sleeping agents, as anticonvulsants, for anxiety, and sometimes as muscle relaxants. But let's talk about indications for elderly patients or those with dementia. If we use a little arc demonstration here to say when we should or shouldn't use certain medications, and we go somewhere from never to always, and you know that basically we don't use those terms in medicine very often, with some gradations of maybe use sometimes with considerable care. And what you find is that for this population, elderly and demented persons, sedatives maybe can be given sometimes if used with great care. As an hypnotic agent, I won't say it should never be done, because there certainly are going to be occasions where the patient really does need to get a bit of sleep at some point, but they should be used very infrequently. Now, as anticonvulsants, clearly there are going to be indications, and obviously in emergency situations they'll need to be used, but as long-term anticonvulsants, you only want to do this maybe sometimes. As anti-anxiety agents, because they are so effective, yes, you may find yourself using these medications a little bit often than for the other indications, but still remember, sometimes with care. And as muscle relaxants, essentially never. For patients who are elderly and who may have a muscle injury or some other reason why they might need that kind of medication for the short term, even for the short term, in these folks, elderly or demented, there are too many potential side effects and too much risk of things like falls, which would only compound the injury, that we suggest you never use benzodiazepines as muscle relaxants. So how do we use the medications once we've identified a valid indication? Well, it's the same thing you hear from geriatricians talking about any medication at any time. And if possible, we need to emphasize that even more with benzodiazepines, that the way to do it is to start low and go slow. Use the lowest effective dose possible for that patient, for that indication, and use it for as short a time as possible also. And the other principle of prescribing is that you should choose the benzodiazepine you use from the proper category. Benzopharmacology is such that you can prescribe these medications vis-a-vis the symptom you intend to treat and have reasonable expectation that it will act as you think it's going to act. Consequently, you don't want to use a long half-life medication for sleep. If your patient has a muscle injury, in quite elderly and demented patients, we don't want to use them at all. If you want to use this medication for a different patient, then you don't really want a short half-life medication used for a muscle injury. Let's say you need something for PRN dosing only for the patient who is episodically agitated. Then it's not going to help if you give them something that's going to take a long time to work. So your best choice is always going to include consideration of both the time of onset and the medication's half-life. So here's a chart of the 10 most commonly prescribed benzodiazepines in no order except alphabetical. And what I'm going to show you in some specific breakdown of this slide is that these medications are exceptionally variable in terms of when they will start working and how long they'll stay in the system to continue working. The rapidity of the onset of action for these medications absolutely does not match how fast they will be cleared from the system. If you look at diazepam versus triazolam, both of them have quick onset of action, somewhere between 15 and 30 minutes in the average patient. But you can see that there's a dramatic difference in the clearance of the drug or the drug's half-life. So attempting to group benzos is quite an imperfect task, but I think there may be a starting point which makes some sense for the choices that you're going to need to make. Let's look at what I would classify as ultra short-acting medications. These are two, Versed, that's very commonly used. I think everyone's familiar with that. And triazolam or halcyon, which is actually not used as often as it used to be, but it certainly is still on the market. What you'll see here is that these have quite a rapid onset of action, somewhere between 15 and 30 minutes for the halcyon, and 20 minutes give or take for PO Versed. The IV use of Versed, yes, this is seconds, between 30 and 120 seconds. The half-life is somewhat different, but both of these can be expected to be in the system based on a half-life of 1 to 4, 1.5 to 5.5. In other words, somewhere around, say, 3 hours each. If we go to the next classification of short and intermediate acting medications, I would put in that group alprazolam, lorazepam, oxazepam, and temazepam, Xanax, Ativan, Cerax, and Restoril. Again, Restoril is not used as often as it used to be, but it certainly still shows up on med lists from time to time. Xanax and Ativan are extremely common. Cerax is relatively common. Now, these medications have a half-life between, say, a half an hour and an hour in general, though Cerax may be a little shorter, a little bit longer onset. And the half-life is moderately variable, but you can guess, if you just want to put an estimate over all these numbers, somewhere in the 8-hour range. And then if we want to move on into what I would consider the long-acting drugs, we have chloridazine epoxide, that is the very first one that was ever developed, clonazepam, commonly used, chlorazepate, not so much used in general practice, but still in psychiatry, and then the venerable Valium. The onset of action of these long-acting drugs is pretty quick, somewhere between 15 minutes and an hour. The half-life, though, is considerably different. Just look at the number of hours involved in half-life metabolism of these longer-acting drugs. Let me show you that with another column added here. Half-life in hours doesn't jump out at you quite as much as half-life in days. If you give a patient a dose of Valium, one who is especially 65 years and older, 1/2 of that medication will still be active in their system for plus days after they take that single dose. If you give them Transine, it's even ridiculously longer at 8 days. So these medications, it's pretty easy to see how one can exceed the therapeutic limit quickly if half of your first dose is still in your system at 4 days, but you take a dose every day. You can see that it doesn't take long for that to build up, sometimes to toxic levels. So let's close this session of our benzodiazepine curriculum by talking about what you should do in interaction with your patient after you have chosen the medication and the dosing strategy that you want to use. First of all, as is the case with every medication, but especially important here, discuss your goals. Discuss the limitations of therapy with the patient, and of course sometimes this will be with a family or caregiver. They need to know the reality of the limitations of therapy as opposed to just deciding what they've heard from family, from friends, from the internet. It has been said that we should quote-unquote adopt a dynamic stance toward reevaluation, adjustment, and discontinuation. In other words, one size doesn't fit all. Every patient needs to be reevaluated, but some patients that might be every few days, some patients every couple weeks. Adjustments should be made and discontinuation planned for, but not necessarily at the exact same time with every patient. You must continue to be a teacher. Your patient is depending on you for accurate information, unbiased information. Now, I think it's interesting that the folks in the some of the articles that we are able to find about prescribing controlled substances will remind you that once you begin prescribing a controlled substance, your relationship with your patient is actually not quite the same. They depend on you to not let them develop withdrawal, for example. But they're also depending on you to not give them too much or not give the medication for too long. That may not be the way they look at it at first, but it certainly is the way you should approach it. And finally, I would say that if a patient turns out to have a long-term need of these medications, a psychiatry consultation is important, and or turning over management of the benzodiazepines to a psychiatrist would be a useful strategy simply because they have more experience and perhaps we'll be able to manage this medication in concert with others that the patient may need. So with this, we will close the first session of our teaching. Please join us for part 2.